Today, we're taking an in-depth look at Irritable Bowel Syndrome, or IBS, and how modern clinical guidelines are finally cutting through decades of diagnostic confusion to deliver treatments that actually work.
And this is such a huge and I think often underestimated public health challenge. I mean, we're talking about a prevalence of around 4.4 to 4.8% in the US, UK, and Canada. It mostly impacts women and people under 50. But the statistic that really measures the severity of this condition, it isn't just the sheer number of people or even the enormous economic burden.
Which is already staggering, right? I saw a number somewhere in the billions.
Oh, yeah. It's estimated between $1.5 billion and $10 billion annually in the U.S. And that's just direct medical costs, excluding meds.
Wow. Okay, but you're saying there's something deeper.
I am. The most, I think, striking data point we saw in these sources is about quality of life. Studies show that patients with severe IBS would voluntarily give up 10 to 15 years of their life expectancy for an instant cure.
That is just a chilling measure of suffering. For too long, the patient journey felt like this endless diagnostic maze.
Yeah.
So our mission today is clear.
Mm-hmm.
We're using new clinical guidelines and some key nutritional research to give you the modern roadmap. We're going to shift the focus from that historical uncertainty and endless testing to a confident, positive diagnosis that leads directly to evidence-based, targeted management.
The foundational transformation in IDS care really rests on a single strong recommendation, and that is abandoning the old strategy of exclusion.
Okay. So historically, IBS was diagnosed only after this grueling, expensive process of ruling everything else out first.
Exactly. It was the diagnosis of last resort.
Right.
The consensus now is a positive diagnostic strategy. This means using established clinical criteria, the patient's history, and a physical exam to rule IBS in. This gets people to therapy faster, and critically, it's way more cost-effective. One study showed annual patient costs were nearly 40% lower in the positive diagnosis group.
Okay, but why would that be? I mean, doesn't more testing give patients more peace of mind? You'd think ruling everything out would be reassuring.
You would think so, but surprisingly, often not. The high-quality evidence shows that all that unnecessary testing doesn't actually provide significant reassurance. I think they leave feeling like the doctor just threw a bunch of tests at the wall, hoping something would stick.
Instead of just listening to them.
Exactly. A positive diagnosis builds trust because it respects the patient's story as the primary diagnostic tool.
So when we talk about a confident diagnosis, we're talking about the Romalan criteria. What are the key components there?
So the hallmark is recurrent abdominal pain. It has to occur, on average, at least 1 day a week in the last 3 months. And crucially, that pain has to be associated with defecation and/or a change in the frequency of stool, or a change in the form of the stool. And the symptoms need to have started at least 6 months before diagnosis.
That 6-month window helps confirm it's chronic.
It does.
That sets a confident stage, but we can't just ignore the possibility of serious organic disease. So what are the two absolute non-negotiables that have to be screened for?
Right. First one is celiac disease. Serologic testing is strongly recommended, particularly for patients who come in with diarrhea, so IBSD. The numbers really bear this out. The prevalence of biopsy-proven celiac is significantly higher in IBS patients, and it peaks at about 5.7% in that IBSD subgroup. You miss celiac, and the patient could face some severe downstream consequences. We're talking malignancies, neuropsychiatric disease.
Okay, so that risk absolutely justifies the screen. What about distinguishing IBS from something like Crohn's or ulcerative colitis?
That's ruling out inflammatory bowel disease, or IBD. For patients under 45 who have no alarm features, so, no bleeding, no unexplained weight loss, nothing like that, we don't need invasive procedures right away. Instead, the strong suggestion is to check 2 non-invasive fecal markers, C-reactive protein, or CRP, and fecal calprotectin. These are just far superior to the older blood tests for accurately discriminating IBD from IBS.
So we know what to run. What about the tests we should now be avoiding routinely because they just don't justify the cost or the patient burden?
The big one is routine colonoscopy. It is recommended against for patients under 45 without any of those alarm features. It's costly, the prep is burdensome, and the diagnostic yield for anything serious in this low-risk group is, frankly, really low. The one exception might be for older patients, maybe women over 60 with diarrhea, where you'd want to rule out microscopic colitis.
And what about just checking for common bugs? Should we screen everyone for infections?
Routine stool testing for pathogens is also recommended against. The yield is just too low unless the patient has specific high-risk factors for something like Giardia. Think recent international travel, drinking untreated water while camping, that sort of thing.
Right.
The history taking is far more important than a blanket test.
Okay, so we've got a confident diagnosis. We've ruled out the major organic diseases. The next step is tailoring treatment, and that means subtyping. Why is getting the subtype right so important?
Because the therapies are highly subtype specific. I mean, what fixes constipation will often make diarrhea worse, and vice versa. And we have to remember, this isn't a fixed label for life. Our sources indicate over half of IBS patients actually change their predominant subtype over a single year.
Wow, really? So you need to keep checking.
Exactly. It underscores the need for repeated objective assessment.
And that objective tool is the famous Bristol Stool Form Scale. We've all seen the charts. Can you walk us through how this scale helps classify the different subtypes?
Absolutely. The BSFS is like the universal language of stool. It goes from type 1, which are separate hard lumps, that's severe constipation, all the way to type 7, which is just watery, no solid pieces, so severe diarrhea. Type 4, the smooth, soft sausage or snake shape, is generally what we consider the healthy ideal.
So how do the Rome-Vivi criteria use that visual scale to classify patients into, say, IBS-C or IBS-D?
It all hinges on a specific percentage threshold. So the patient has to classify their bowel movements on days they have symptoms, and at least 25% of those movements have to fit the definition. For IBS-C or constipation predominant, that means more than a quarter of bowel movements are type 1 or 2. For IBS-D, diarrhea predominant, more than a quarter are type 6 or 7. If they meet both criteria, that's IBS-M for mixed, and if they don't quite fit the criteria, they're classified as IBS-U for unclassified.
All right, let's move to the frontline treatments. Before we get to prescription pads, let's talk diet and lifestyle. Beyond the basics, eat smaller meals, limit fatty foods. What are the specific evidence-backed nutritional strategies?
Well, before we even dive into food, we have to highlight the one thing that's universally beneficial: physical activity. Just getting 20 to 30 minutes of moderate activity most days of the week helps with motility, with stress, and with overall symptoms across all subtypes.
Okay, now let's talk fiber. This is where it gets tricky, because everyone is just told, eat more fiber. But not all fiber is a friend to the IBS gut, is it?
Not at all. This is a crucial distinction. We strongly suggest soluble fiber. That's the kind you find in psyllium husk, oats, barley. Soluble fiber acts like a gentle sponge. It dissolves in water, forms a gel, and that slows transit time and improves stool consistency. It helps with both diarrhea and constipation.
And what about the rough stuff, like bran flakes?
That's the insoluble fiber wheat bran, raw veggies, that kind of thing. Insoluble fiber is not suggested for global IBS symptoms. It's roughage. It basically passes through intact. For a colon that's already hypersensitive and irritable, that can just increase gas, bloating, and painful cramping. So if you're going to increase fiber, go slow, use soluble sources, and make sure you're drinking enough water.
Okay, now for the big one. The infamous low FODMP diet. Our sources say a limited trial is recommended, but the evidence quality is still really low. If the evidence is weak, why is it still such a frontline intervention?
That's a fair question. The evidence is complex, mainly because diets are just notoriously difficult to study rigorously. But for the patients who respond to it, the diet can provide profound relief. The theory is sound. FODMPs, these fermentable short-chain carbs, are poorly absorbed. They comment in the colon, drawing in extra water and producing gas, and that leads to that classic pain and bloating of IBS.
It sounds simple. Just avoid those foods. But you mentioned the sources stress how complex this diet actually is.
Oh, it's a 3-phase intervention. It is not a simple elimination diet. Phase 1 is strict restriction. Phase 2 is systematic reintroduction to find your personal triggers. Phase 3 is personalization. And the sources are emphatic on this. Due to the risk of nutrient deficiencies and just how hard it is to follow, this process critically requires the guidance of a registered dietitian.
So don't just Google a list and try it yourself.
Please don't. It often leads to failure and unnecessary nutritional risks.
Okay, what about gluten? A lot of people cut out gluten even without a celiac diagnosis.
Yes, and routine allergy testing isn't recommended for this. What's often happening is a case of mistaken identity. The person is likely reacting not to the gluten protein, but to the fructans, which are a type of FODMP found in wheat.
Ah, so the low FODMate diet would catch that anyway.
Exactly.
Let's touch on 2 over-the-counter options. First, peppermint oil.
Peppermint oil is suggested particularly for abdominal pain. It's a simple, smooth muscle relaxant. But And this is important. You must make sure it is enteric-coated. If it dissolves in the stomach, it can cause some really bad heartburn.
And finally, probiotics. The darling of the wellness world. What's the clinical verdict?
The current evidence suggests against using probiotics for global IBS symptoms.
Really?
Yes, the results are just too inconsistent. There's massive heterogeneity across the studies, different strains, different doses. It's impossible to currently recommend a specific regimen. The evidence just isn't there yet.
Okay, so if diet and lifestyle aren't enough, we turn to targeted pharmaceuticals. And this is where knowing the subtype is absolutely essential. Let's start with constipation-dominant patients, IBS-C. What are the heavy hitters?
For IBS-C, we have strong recommendations for a class of agents called secretagogues, specifically the guanylate cyclase activators, or GCC agonists, like linaclotide and plecanatide. They're backed by high-quality evidence. They work by stimulating the intestine to increase fluid secretion and speed up peristalsis, and they also help reduce visceral pain perception.
That dual action sounds really effective. What's the main drawback?
Diarrhea is the most common side effect. It can affect up to 20% of patients on the higher dose of linaclotide. Then you have another class, the chloride channel activators, like lubiprostone, also strongly recommended. They work in a similar way, increasing secretion. The main side effect with this one is often nausea.
Now, a lot of patients with constipation will just try standard osmotic laxatives like PEG products.
Yeah.
Why are those suggested against for global IBS-C symptoms?
This is such a critical distinction. PEG products are excellent laxatives. They absolutely improve stool consistency and frequency, but they're suggested against for global IBS symptoms because they do not effectively alleviate the defining abdominal pain.
And since IBS is defined by the pain.
Exactly. If the treatment only fixes the bowel habit but not the pain, it hasn't effectively treated the syndrome.
That makes perfect sense. Okay, switching gears completely to the diarrhea predominant subtype, IBS-D. What's strongly recommended here?
That would be the non-absorbed antibiotic rifaximin. It's strongly recommended, and it operates on the hypothesis that some IBS symptoms are driven by an abnormal gut microbiome. Because it's not absorbed into the bloodstream, it has a highly favorable safety profile. It treats the gut locally.
And for severe cases that don't respond, what are the other options and what are the big warnings?
For women with severe symptoms who have failed other treatments, there's allostron, but its use is conditional due to some historical safety concerns. More recently, we have aloxitolene. It's suggested for improving global IBS-D symptoms in both men and women. But the crucial warning here is it has absolute contraindications, particularly for patients without a gallbladder or a history of pancreatitis or heavy alcohol use.
Finally, let's talk about the one drug that seems to span all the subtypes by targeting that core symptom, pain.
That would be the tricyclic antidepressants, or TCAs. They are strongly recommended for treating global IBS symptoms, especially that visceral pain. They act as neuromodulators. They can slow GI transit, which is great for IBS-D, but mostly they just dampen the pain signals traveling along that gut-brain axis.
And the success rate is pretty high, right? The number needed to treat, the NNT, is 4.5. What does that actually mean for a patient?
That's a great question. It means that for every 4 or 5 patients we treat with a TCA, one person will experience significant symptom improvement who would not have improved otherwise. That is a very strong success rate for a chronic pain condition.
And that leads us perfectly into the gut-brain axis. We know psychological factors like stress, hypervigilance, and fear can really drive symptom severity in IBS.
Absolutely. And this is why gut-directed psychotherapies, or GDPs, are so valuable. We're talking about things like cognitive behavior therapy, CBT, and gut-directed hypnotherapy. They're strongly suggested. They target the cognitive and affective drivers of the symptoms.
What's the unique advantage of these therapies compared to, say, a medication?
Well, they're very low risk, no serious adverse events reported, and they're subtype agnostic. They work just as well for IBS-C and IBS-D. And crucially, they show long-term benefits even after the therapy has ended. The NNT for symptom improvement here is actually 4, so slightly better even than the TCAs we just discussed.
It's like teaching the brain to turn down the volume on the gut.
That's a perfect way to put it.
Okay, before we wrap up, a final mention on a hot topic: fecal microbiota transplant, or FMT.
Right. The current evidence for FMT is of very low quality and it's inconsistent. The clinical guidelines strongly recommend against using FMT for global IBS symptoms at this time. It is simply not ready for prime time.
So, to summarize the key takeaway for you, the listener, Effective IBS management today is a highly personalized, stepwise process. You start with that confident, positive diagnosis, you maximize lifestyle changes like focusing on soluble fiber, and then you move confidently to highly targeted pharmacological or psychological therapies based on your specific subtype and your symptom severity.
The whole field has moved beyond just shrugging its shoulders. We have specific tools. But if we connect all this to the bigger picture, especially for those with constipation symptoms that just don't respond to drug treatment, there is one major physical mechanism that's still frequently overlooked.
You're talking about a mechanical problem.
Exactly. What really stands out in the research is the recognition of pelvic floor disorders, specifically a condition called dysenergic defecation. It's where the muscles and sphincters just don't coordinate correctly to allow for easy evacuation. And it occurs across all IBS subtypes. The prevalence can be as high as 40% in some practices.
So people think they have drug-refractory IBS when really the mechanics are just off. And that brings us to our final provocative thought for you to chew on.
Anorectal physiology testing, things like anorectal manometry and balloon expulsion testing, are suggested for patients whose constipation is refractory to standard medical therapy. And biofeedback is a highly successful treatment for this coexisting mechanical condition. It basically teaches those muscles to coordinate correctly again.
Therefore, maybe the biggest overlooked aha moment in modern IBS care lies not just in balancing the gut lining or calming the brain, but in fixing the physical mechanics of defecation itself. You may want to explore how often this highly treatable mechanical dysfunction is missed in favor of just prescribing more drug solutions, when the answer might be as simple as retraining your body.